Welcome, friends, colleagues, students, citizens of the world. It's my extreme pleasure today to have an amazing guest that I met a while back at the International Congress of Oral Implantology with an amazing story, doing amazing work out of the Florida area. I can tell you, I run into doctors from time to time that speak a good game, and when you follow them, you're like, that doesn't quite add up. And then there's doctors like Dr. Hassan where you meet them, they're humble. They start dropping little hints of where they're at, what they're doing, the level of clinical work that they are capable of. And then when you follow them, they absolutely demonstrate that. And so it is with my great pleasure to bring on an amazing clinician, an amazing person that we have the pleasure of being colleagues and friends, Dr. Amel Hassan. How you doing, my dear?
I'm doing great. How are you?
I'm doing good. I am so glad that you carved out, you know, 35, 45 minutes for me on a weekend, on a Sunday. I'm honored and I'm privileged, so thank you so much. You're in the Florida area, right?
Correct.
Okay. And for anyone that doesn't know your story, in less than a minute, how would you sum up where you've been, where you're at, what you do?
So, for people who don't know me, I'm originally born and raised in Sudan, East Africa. Moved to United States in 2007 to find that I have to join the dental school for the second time. So I guess that is the biggest thing in how much I love dentistry, because I decided to do twice in my life. Joined NYU, graduated in 2014 with my DDS degree, and just went back to Illinois because Illinois was home for me at that time to just practice as a general dentist, associate dentist, just joining corporate America.
Okay. So you're originally from Sudan,
Correct.
correct? And that's where you did your dental training at initially?
Yes, that's in Sudan. Usually you finish the high school and then you just join college from there. So that's what I did. And the dental school back there is 5 years. So I graduated the first time in Sudan with a Bachelor of Dental Surgery. That was in 2004. Came here after I did my residency back home. Came here to find out that the degree is not really recognized here or does not um, provide me with a dental license in the United States. So for me to just get a license, I have to go back to school, which I did. It wasn't the easy decision to do, but I think it worth it.
Okay. And that's funny because I'm originally from Greece, and they're the same thing. There's no 4 years of undergrad while you figure out your life. You do a standardized test that kind of tells you what programs you can get into, and it's generally 5 years for dental school, right? What do you think about the two systems? One where you have to do 4 years of an undergraduate education, and so it's a minimum 8-year process versus if you already know you want to do dentistry, you test into it, and in 5 years you're a dentist. How would you compare the two?
I think the system we have back home is more um, into I like it better if I have to choose because it gives you more of your young years into your actual doing the work. By the time you finish dental school and you go out, you're like 22, 23. You're done with everything. And part of the system back there, maybe because you join very young, the general practice residency is not an option. Here in the United States, it's an option. You can decide to go for general practice residency, a GBR year, or you don't have to. Some states make that mandatory. One of them is New York. Some other states, they don't really care. You can just have your degree and start practicing. Back home, that is not an option. You have to go through the general year of residency, which is I see the value of. A lot of us in the dental school, you get trained, you get the didactic part, you learn about things in a theoretical way. Yes, there is clinics, there is patients requirements that you have to fulfill before you graduate, but I just don't believe that's enough for someone to gain the confidence to be able to deal with the big patient volume after they graduate. So I believe that the general practice residency 1 year is needed. It should be mandatory. And because we finish at a younger age, it actually makes more sense. Here you spend 8 years. Some people will think, oh, it's too much for me to go and spend another year, or maybe they'll say I'll waste another year. I don't believe it's a waste. It's needed, and it's going to make your career more successful and more confident, and it will give you that level of experience, the minimum level of experience, I want to call it, for you just to go into the market and start doing this on a bigger scale.
Okay. You make some valid points there. And I think for anyone listening, you really have to realize you did dental school twice. So you're twice the dentist than your average dentist out there, right? Which I think it's an amazing and a courageous decision to make because you loved dentistry so much. After you came here, you knew there was no other path for you and it was worth another 4 years of your life, right? But I think that's a great segue into this next segment because I want to pick your brain. You are the expert. You are, and as someone who was a general dentist and who specialized in implants as a general dentist and now a periodontist, there really should be a recognized specialty of implantology, right? And I know a lot of states have actually thought about creating that as an actual recognized specialty because it's its own niche. The amount of expertise you have to do what you do is very vast and specialized, right? So I got some studies I want to pick your brain on because it's discussions that are happening around the world of implants and implant supported structures, whether they're removable or fixed. Okay, so I'm going to share my screen here.
Yes.
Okay, perfect. So I get a lot of questions, especially about kind of the full arch world.
Oh,
And
yeah.
what tends to happen is there's a lot of people that are either traveling dentists, traveling surgeons, they do implants at multiple offices, and then they leave. So everyone has geographic success. And the data showing that when it comes to the peri-implant disease in a similar fashion that we see in periodontal disease around natural teeth, there's a certain level of disease that you can expect that you might have to mitigate. And we know that when it comes to just inflammation, right, peri-implant mucositis,
Mm-hmm.
it, depending on the study, you're looking at anywhere from 40 to 50% of implants have some type of active inflammation around them. When it comes to peri-implantitis, where it's not only inflammation of the gums, but you also have bone loss,
Bone level.
depending on the study, the average between all the different systematic reviews is probably around 1 in 5, 20%. I'm going to unshare here. Now, given that in implantology you have that much disease present and you're dropping screws left and right, you only, for the most part, do implants. Like I said, you're not doing the root canals, you're not doing the fillings. How do you mitigate that disease? Are you seeing that level of disease? And how do you follow up with your patients post final delivery to ensure that you either diagnose disease and then treat disease?
So that's a good question because now we are at the after, right? Everybody's excited to place implants. Let's all learn how to do it. Let's just put it in. And as far as what I see with me being a mentor, people are just excited about the part where they basically prepare the osteotomy and put the implants in there, and that's implantology for
Wow.
them. It's
Yeah.
like it's now with a lot of patients being receiving implants, a lot of doctors are being trained, different levels of training, placing implants. Yes, we are going to see an increase in peri-implantitis because just by nature we have more people who are prone to this problem by just the fact having an implant in their mouth, right? So the number of the population of the patients are growing in that regard. However, there is things that peri-implantitis can be iatrogenic, which means it's been happening due to the lack of the knowledge on the provider who placed this implant to begin with, not considering, because implantology is all more like, do you have enough bone? Nobody is talking about the soft tissue. Like, I have enough bone, I'm good to go place the implant. We know now it's bone and keratinized soft tissue, right? It's bone and tissue. Tissue is the insurance, if anything. We even have some cases where the amount of the bone is not like the best. We barely have the minimum, but because we have a thick keratinized tissue, the implant is actually doing very well over the years. Versus some cases where I have tons of bone, but nobody here cares about the amount of the keratinized tissue, at least the bare minimum of 2 millimeter to be present around this implant. Now we're having issues. We start with mucositis and then we start getting to peri-implantitis, and issues goes from there. So I believe we have an obligation first as dentists or implantologists, or you even as a general dentist who wants to do this. I'm not against a general dentist who would like to do this, because as I said, I'm one of them. But I just quickly learned in the process, this is not just only, even though I have it in my hand and say, let's drop some screws, it's not about just dropping the screw and running away, because the screw is always going to be successful in the first year after the initial osseointegration. Am I only about the success on the short term for the first year or so? I want to see my implant in 5 years, in 10 years, how those implants that I placed 10 years ago are looking today, right? And how do I carry that? And yes, in my practice, I see it. And sometimes I learn through my own mistakes, right? Because sometimes, even though we be a little bit hardened about things, I'm like, you know what? It's minimum here, but I'll hope for the best. Now we know we're not supposed to be hoping for the best. There is ways for us to prevent that, because again, it's the obligation, the ethical obligation I have towards my patient. They come back to me. Follow up and maintenance is a big thing. A lot of patients, it's a big investment. They come and they said, okay, I pay all of this money so I don't have to worry about anything. I said, no. When you buy a Lamborghini car that costs you a lot of money, you take that car for maintenance. If you buy that fancy house that's $1 million or $10 million, you have to go through house maintenance to keep your investment. These implants are investments. You paid money for them. I will need to see you here once a year. I had to see my overdenture patients once a year, because I tell them your inserts, your retentive bands are gonna get wear off. Those are just, think about them. And I try to use sometimes language that relates to patient, because we also have to understand as professional, people don't understand the terms that me and you speak about it as if it's given, it's easy for us to understand. For them it sounds Chinese, they don't understand what we're talking about. So I said, you have this implant, this head of implants, and I have models, because people are very visual. We have an obligation not only to execute this in a correct way in the surgery room, is to educate the patient about what they are getting. And again, the same way I always say, not all dentists are supposed to be an implantologist. Not all patients are supposed to receive implants just for the simple fact that they have the bone. If they're not understanding the maintenance of this treatment I'm delivering in the mouth, we cannot go to the next step before we have a full understanding on that.
You know,
Because I want to see you.
I'm gonna have you say that one more time. I love that line. Not every patient should be an implant patient. I think that is so important.
Even if they have the bone, they can have all the bone on earth, they can have all soft tissue on earth. If they
Right.
don't understand what it takes for me to put this in their mouth, I don't want to be the dentist who's going to place that in their mouth and I know it's going to fail.
Right. And that's a perfect segue to the next piece of literature that I have. I'm going to share my screen again. Okay. Do you see that there? Perfect. Okay. So
That's my paper.
that is your patient. So I snagged this from your Instagram because I think it's, at some level, I also want to play devil's advocate, right? We know that there's a whole slew of risk factors, systemic diseases, whether it's diabetes, smoking, bisphosphonates, head and neck radiation, that are significantly correlated with increased implant failure, right? One of the other factors that often I see goes unaddressed is history of compliance and presence of periodontal disease, right? And so for anyone that's listening to this and not watching, we got a study here by Matteo Cerrone that looks at the success rates in patients that have a history of I take that back. They have a history of periodontitis versus patients that don't have a history of periodontitis. And what we see is that the incidence of peri-implantitis had a risk ratio of over 4 for patients that had a history of periodontal disease. Okay, now I'll exit out of here so we can chat about it. And so if we know, if there's one thing you can tell about your patients when they come in, if they've spent 30 years neglecting their natural teeth and they have a lot of bone loss, decay, they might even present to you full of plaque and calculus. How do you make the decision on when you can trust a patient with the Lamborghini if for 30 years they didn't even take their natural Toyota, Lexus? They didn't take care of it. How do you make that distinction between this patient can get implants and this patient can't?
So it depends on the situation, because sometimes when they come to me, the teeth are already terminal. Like no matter what, these teeth have to go, all of them. Like I deal with a lot of patients who are full mouth extractions patients. So that we know the teeth are terminal. Now there is no periodontist who can come here and save these things, because we got mobility, we got all type of pockets. Sometimes we even have bus and things that this is just going. And now one of the things I think it's big, because people go through different stages in their life. I don't know what was going on in the life before, before they got to this point. I believe also motivations do a big part of this. I would have to sit down with this patient first and have an understanding of what happened in the past. How did we get here? If all what I hear is you trying to blame somebody else and you're trying to say this, some people will own their mistakes and they'll say, you know what, it's my fault. I didn't do this. I didn't do that. I was supposed to do this. Sometimes, yes, I tried to go to the dentist, but I didn't have budget. I was having this going on in my life. And now we have to consider all of these factors. And I hear the story. What's going to happen in the future, looking at studies like this, now as being not only the doctors who's going to do this treatment, I have an educational part to do here. I'll say, okay, Mr. Smith, this is what the science is telling us. You're someone who have a periodontal disease. You are at a higher risk. You're 50% higher risk actually of getting peri-implantitis, which is a gum disease that can happen around your implant. The same way you're losing your teeth today, we can lose the implant for the same reasons. That is not going to be a contraindication 100% for me to give you, especially in cases it's an easier decision for me to end up doing the treatment if I'm dealing with a full mouth extraction and I hear the patient, because I'm taking everything out. It gets a little bit tricky for me, and I'm more tough with that decision when I'm just doing a single tooth implant in a mouth that have natural teeth that they're going to stay, but they need some perio treatment. The first, that one, I of course have to send this person first to the perio to go stabilize. Please, I mean, common sense that it may sound, a lot of people don't do it. Please do not place implants in active perio situations. If the perio is active, what I'm really trying to do here, like this is a piece of metal. Implants don't have BDL. They don't have blood supply of their own. They have, if anything, they have less capacity to heal and to resist all type of things that natural teeth can resist. So I'm just setting myself and this patient to failure. And maybe it's an easier test. If you cannot put your perio under control, it's an easy decision. I cannot place the implant. You made it easy for me, because you have to prove to me that you can get rid of the disease or put the disease under control for me to trust you with the implant. Because guess what? When the implant fail, you're gonna come at me and ask me why my metal screw failed.
Oh, they're gonna
Metal
blame you. They're gonna blame you for right off
It's
the bat.
always my fault. So show me, if you show me that you put your period under control. And as I said, I want to judge people life. Sometimes things happen in people's life in certain stages that they become depressed, they become this, they're not taking care of their teeth. And now they're picking it up. Okay, show it to me, prove it to me, I can deliver it to you. When someone comes to me, okay, the teeth are terminal, we're at the stage of taking everything out, we sit down. My consultations are always no less than an hour. First time I'm sitting with the patient, even sometimes my dental assistant will come from outside and they wave, like they want to get me out of the room. I said, no, I have to be in this room. I have to finish up this talk, because it's going to be too late for me to have this conversation after the fact. I treat this patient, and even if anything happened afterwards, because again, we all have license to protect. That one level. Another level of it, we can always do it the right way, and it's not difficult. That's sometimes what really bugs me, like doing the right thing and executing the treatment at the right timing and saying no when it's needed to be said. It's not that difficult, and the outcome are actually going to come even much more better and much more beautiful. We just have to have the knowledge to do it. We have to have the courage to do it, because sometimes we know that this is not going to work, but yet we go under the pressure, or the patient is going to pay, or I think those are stupid decisions, because you
Right.
can always make the money by doing the right thing and saying no when it's needed, and saying and make the patient aware of the risk factor, communicate those things. Nobody's perfect. We're not here to judge people behavior or judge people, what they were doing in the past, but we have an obligation just to set the expectations. This is what your responsibility is, this is what my responsibility is going to be, and then after I deliver these teeth to you, you have to do 1 2 3, because you have this systemic disease. A lot of people underestimate, not only we're talking about periodontal disease, diabetes is a killer, because we can't get rid of it. There is no 100% cure for it. Your diabetes have to be good today for me to place the implant. But do I trust this to be good all the time? Now I have to explain to you the risk and benefit, and what we can do. I think those are all obligations that any implantologist should be aware of. Implant dentistry is not all about making a hole in the wall and putting a screw in there and then hoping that the best is going to happen. The best is never going to happen if you don't have a plan, if you don't have a comprehensive approach to reach these things. And it is not only about bone.
What does your screening process look like? So let's say someone says they are diabetic. Do you get medical consults? Do you get confirmation of records of what their A1C is or what it's been?
Absolutely. I
What does
always
that look
get a consult, but now would really want to say something about the consult, because a lot of us thinks that a consult, or since I did the consult and the physician told me to proceed, I'm good. I am not. I asked for the consult, but not because I want to know from the physician should I proceed or before I send the consult, I know am I proceeding or no. I just need the consult as a protection layer in my documentation process to be there, but I am the one who's delivering the treatment. I am the one responsible. I cannot, I treat every case, doctor, as if I am defending myself in court. I know that may sound kind of
That's what
aggressive,
you got to
but
do.
every case
You
I
got to
am
do.
doing it as if I'm standing in front of the judge, in front of the jury, and I'm explaining why I decided to do what I did in this case. Yes, I want a clearance because it's an obligation. I have to communicate with the physician, and it's a second, it's a protective layer for me there. But I'm the one who have to know, am I good to proceed here or no? I mean, I hope all of my colleagues would know that. You're not waiting for the physician to tell you to proceed or no. Diabetes is affects the metabolic rate in the bone, affect the osseointegration process in the bone. Diabetic patient are a higher risk to lose their implants if things are not done right. If the diabetes is out of control, you want AC, and I want my colleagues out there to be familiar with ordering these tests. You don't have to send the patient to their doctor to order a test. I know how to order my test. I write it, I give it to the patient, I sign in there, I send it to the lab. I need the 1AC. You ask the patient. If the patient doesn't even know what a 1AC is, we're having a problem. We're not going anywhere.
Right.
Because obviously, if you don't know what a 1AC is, you're out of control. You don't keep track of your sugar level, right?
So what are some of your cutoffs systemically for some of the different conditions? So let's say you do get a A1C test, or they bring. So a lot of patients have their records on their phones. They can say, hey, this is my. What are your comfortable ranges for some of these conditions?
My cutoff to place implants for a diabetic patient is 7. I don't want to place an implant on anybody who is more than 7. And even the 7 is like, okay, I will place it and I wouldn't do an immediate load on you. Because also systematic reviews and studies showed us diabetic patient, when it comes to the immediate load, the outcome is not really great. So we would love to let these implants also integrate, then we load them. If I'm doing an all on X, let's say for a diabetic patient, my cutoff point is not going to be 7, it's going to be less, because if you want me to immediately load, I need to see a 6 or 6.5 at the most. Otherwise, I'm not immediately loading. I can still place the implant, but we have to wait for those integration. Then I will load you after the fact I had some integration happen.
And is that a singular 6.5, or is it a pattern? Because one of the things we've seen over the years is, let's take a index like your plaque index, right?
Hmm.
If you come in and we get you on board, you got active periodontal disease, your home care is not good, and we do one round of, say, deep cleanings. You come back, and that one time, your plaque score when you come in is 15, 20%. We're like, hey, okay, that's great. Let's proceed with everything, right? With the A1C, because I've seen patients where you look at their record and you'll see 10, 9, 10, 8, and then because they really want these implants, they really are good for 3 months and they get it down. Do you feel confident at that point, or do you want to see a longer pattern of glycemic
Of
control?
course, a longer pattern, because even when they're good, like they're always around the 6, the 6.5, I always let them know this is not a one-time number that we would like to see, because your implants are going to stay in your body for the rest of your life, hopefully, or for the coming 20 years at least, without problems.
Right.
If you mess up your control, if you stop taking your medication, if your 1AC goes up, that can go back still after the fact your implant are osseointegrated, are going to hit your implant negatively. So you make sure that, yes, again, I use a lot of examples from construction, sometimes in the car world, to the patient. I say, you take care of your house, you do the cleaning, you do everything, and then you all of a sudden stop doing it, and you start now having mold. It's not going to save the house for the fact that you've been saving everything for the past, so, and now you already did that, you already have mold now. It's a continuous process. It's an ongoing care that not only for your implants, and trust me, a good percentage of the patient will actually appreciate, and they said, you know what, doc, nobody told me about this before. I wasn't even aware that these things are kind of linked together.
Hmm.
And I think we have that obligations towards our patients to do the educational part of it. We know this information in our heads. I hope we all know it, because I mean, it's a sad fact that sometimes I see things coming from colleagues that people don't have the minimum understanding about medical history. People don't feel comfortable. They're just waiting for the physician on the other side to tell them yes or no. Sometimes a patient is on a Blavix or something, they send it for the physician to stop the Blavix. I said, do you even know how Blavix works? What is Blavix? What is the mechanism of action? Do you know that this is just an antiplatelets, and how long then you want to take the patient out of the Blavix here for it to be effective? Like, you wouldn't just take a day or two, it's not going to work. This have to be at least 5-7 days, because that's the effect of it, and before you can go. We all have to know these things if you want to be good about doing your implants. Your implant does not happen in the vacuum. They are linked to the bone. The bone is part of somebody's body, part of somebody's medical history for their general health. If the patient is a smoker, if the patient have a period disease, if the patient have diabetes, and I always keep saying diabetes, it's the bigger killer. Diabetes and periodontal disease are your biggest enemy here when you're talking about implants. Patient is on blood thinner. People get scared to touch people on blood thinner. These people need somebody to treat them. But you need to know, when are you touching, when are you not touching. And you need to know, why are you stopping the blood thinner. Do you know that the studies told us, the literature is telling us, the risk of stopping the blood thinner way over me having bleeding chair side for this patient. And do I have the training and the skills to know how to deal with the chair side bleeding? Because that would not kill the patient if I know how to deal with it. If I just have the small little elements in the office or the material that I need to use to just stop a bleeding, and instead of me asking the physician to stop the 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 blood thinner for the patient and put them at higher risk to get a heart attack and kill them and get a thrombotic. I mean, I think it's a lot of ignorance sometimes from the provider side, and I'm saying this not to attack some of my colleagues here, just to up your game. Up your game. If you want to be good at this, it's not impossible, but it takes a lot of training. You can't just decide that you want to do this or do that without going for the training for it, without
And
knowing
continued
what
learning.
it takes.
Continued
And
learning after that.
because things are changing.
They
Things are
are.
changing.
So back to this case. If you have existing teeth and you're doing a single implant, I guess that opens up Pandora's box of questions for me. One, if you're doing the implant on a single implant case, do you mandate that the patient have a general dental home to quarterback the overarching restorative plan for the patient? Or are you taking the patient on as you are the dental home now, right? Because presumably, what if the patient needs root canals or fillings or anything like that, and you only do implants? You not only have to potentially refer the patient to a periodontist if they got active perio, but presumably you would have to communicate with their actual general dentist to say, hey, this patient needs an implant. What is your overall restorative plan? Are there any other pending needs that you think need to be done first? Where does your communication and obligation stand in regards to the patient having an actual dental home?
That is always a must because a lot of times when people come to me for single tooth implants and the rest of the teeth are okay, but they need some maintenance work, they need some filling sometimes, they might need a root canal here or just as simple as a filling. Because before we get to a root canal and things getting worse, we need some filling. Sometimes you go for your regular every 6 months cleaning. So the patient comes and they say, and it's always the story about this tooth. I just want the tooth here. And then you look, there is no posterior teeth, or some of the posterior teeth need to be saved by a root canal and a crown, otherwise you're going to lose that tooth. I need to know what's going to happen in the back before I even make my plan here. So I'll sit with the patient. I'm not the one who's going to work on those root canals. I'm not the one who's going to do crowns on those teeth. But now me and you have to have a conversation. This is what needs to be done in the back. And I have to explain. A lot of patients will ask me, Doc, I'm just here for the front tooth. Why are you telling me about my posterior teeth? I'm fine. Like I just gonna leave them. I said, I'm sorry. It doesn't work like that. It takes upper and lower to have a full arch of teeth, and your front teeth are your weakest teeth. And there is a reason why actually you lost this tooth. And you're about to lose the other one too because you don't have a posterior bite. You don't have nobody to do the work back there. Your front teeth are doing more much than what they're supposed to be doing because these are single rooted teeth, they're small. All of these things, first I have to have the knowledge about that and have to be able to see that in my head as the provider, and then communicate that with the patient. And then from there we're going to see where we're going with this. Is this patient would go, and most of the time, believe it or not, they go, like they go to their general dentist to have those things done, and then you come meet me and then we deal with the front teeth. Or some people will say, you know what? I don't think I want to do that. That if the tooth is gonna need the, especially when it comes to the level of root canals, a lot of people have the misconception. Even though, as I said, I'm not the root canal dentist, but trust me, my friends, I try to save you and try to make you look good when the patient comes to me, because people blame the root canal. They said, "Oh, I had a root canal before, and the tooth is gonna break anyhow." I said, "But did you ever crown that tooth?" They said, "Oh no, nobody told me." I said, "No, a root canal can be done and can be successful in just a remaining root sometimes, right? It's doable. But it's not about doing the root canal, it's about the restorability of that tooth." And a lot of patients don't want to go for the root canal. But yes, to give you your answer is some patients they need to go. And that's a must because guess what? I want my implant to be successful. That's all what I care about. Like I'm focusing on my part. But sometimes for my part to be successful, I have to mention some other people parts to be taken care of, especially the story of front teeth. And we know, like aesthetic zone in the maxilla, we all be careful like when we want to deal with that. Sometimes even in the back, if you don't have a posterior bite on one side, you only want to add, or some people just stop at like premolar, or they don't have bites in the back. It all have to do with the bite, with the occlusal scheme. You can place the implant back there. The patient keep coming back with a loose restorative screw every time, and the crown every time gets loose every 6 months, and people wondering what is happening here. Can you just slow down? It's a
Right,
force issue now. Your
right.
occlusion is off.
As a clinician at Affordable Dentures, let's say when you do a single implant crown in the anterior, are you doing just the implant and the restorative doctor is doing the restoration, or are you doing the restoration too?
I do everything. I am the
Okay,
surgical doctor and the restore. So my mistakes comes and bites me. That's why I'm very
right.
particulate about, yeah, I restore and I do the
So
surgical
then
part.
how do patients get to you? Are they referred by general dentists? Are they walking in because it says affordable dentures and implants? And then, because my presupposition would be if someone says, oh, I know I need an implant, someone told me years ago, I'm gonna go to Affordable Dentures and Implants and get my implant, right? I haven't seen a dentist in 5 years. And you say, okay, you need to find a dental home first. There's a lot of general dentists, at least restoring implants. So that, I guess that's where my curiosity comes from. Because, to be very honest, when someone refers to me, I first ask, do you want to do, do you do the restoration, or do I need to find someone to do the restoration for this case? If they say yes, then great. Then we coordinate accordingly, right? But if they're coming to you right off the street, but you're also wanting to do the restoration, and then you refer them to a dentist, how do you maintain control of being able to do that implant start to finish, and then that dentist not just saying, well, I can restore it, and if you don't want me restoring it, Dr. Hassan, I'll just send it to my specialist to place the implant so I can restore it. Like that,
So it
what does
makes
that
a
look like?
difference if the patient is coming from the general dentist to me and they only want me to place the implant and send them back for the restoration, then I do respect that
Mhm.
because that is their patient to begin with. They just need my help with the surgical part of this story and then send back the restoration to them.
Mhm.
However, if the story is flipped, the patient is mine, they came to me the first time, they don't have a dental home. I'm the one who's referring this patient to you to take care of their general dentistry needs as far as fillings, crowns on natural teeth, and cleanings, then I am the one who restore and place the implant, unless the patient wants otherwise.
Right.
But that's how usually the way I do it.
Okay, that's it. So there's a lot of politics in this field.
It is just being respectful to my colleagues out there because at the end of the day, it's not about that one patient. Am I here about developing the connection and the relation with my colleague and maintaining that going on? Or I'm just being greedy about one single case where I can place the crown, but I just like he said he will place it and I say, no, I want to keep that. And no, I think that is stupidity sometimes when people get greedy about small little things like this.
Mhm.
And it have to be about the relationship between you and your colleague and the patient being in the middle providing care for them, because I have no doubt that if the patient chose to do it there and that's their patients to begin with, they came to me, I'm not going to say for me to place the implant I have to restore it as well. I have no such a thing. I can place
Right.
the implant and it can get restored somewhere else.
Gotcha, gotcha. Okay, one last slide I want to share for you here. Now, as I'm gearing this up, when you do your full arch cases, are they predominantly removable or are they predominantly fixed?
So I do different range of things here. I can even do just the regular denture with no implants, no what. It's just patient doesn't have the budget. We're just gonna be doing regular full dentures, or we can do an overdenture if the budget allows us to do that. Sometimes upper and lower, sometimes just mandible if there is no budget for it. If we have the budget to go for fixed full arch, I do that as well. So I do fixed full arch, I do overdenture, I do regular dentures, and I do single implants and implant bridges as well.
Okay, proportionally though, on your full arch cases, are the majority removed or fixed, would you say?
The majority are in the overdenture
The overdenture.
zone. That's where we are.
And I'll give you my 2 cents on that. I think the overdenture is probably the lowest risk of all the different options you can do. There's obviously the non-implant denture, right? But we know that especially on the lower standard of care is
Is
always,
not a
if
standard of care.
possible,
Yep.
two implants, right?
Mhm.
But when you look at fixed, because of the cost of the final prosthesis and the multiple steps, and as we've said, there's the incidence of peri-implantitis, 1 in 5. I know there was a great study by Rosen in 2024 that looked at what they call the cluster effect, that the majority of implant failures tend to happen in a small percentage of your patients, whether they are a hyperinflammatory state, habits, smoking, or like you said, uncontrolled diabetes. And then we always have those patients that every time you touch them, it just never goes well, right?
Mhm.
That being said, the removable option I think is great because if something does go awry, it's not catastrophic. With the fix, it's a bit more, yeah, it's a bit more of a labored process when you have complications, right? Removing the prosthesis. And that's one thing I wanted to bring up this Lanzetti article where it's a systematic review looking at what all the different literature says out there about how to maintain these patients post delivery. And there's a multitude of studies that says one of the highest risk factors for implant complications is whether or not the patient is compliant with their maintenance schedule, right? And maintenance around natural teeth is easy. You come in, you get your cleanings, we probe. But when you have a fixed prosthesis, especially fixed more than removable,
Mm-hmm.
here, this particular study said that given all the data, practitioners should consider performing professional oral hygiene measures every 6 months and removing a prosthesis, even a fixed prosthesis, at least once per year. And the hygiene measures was a combination of different protocols, whether it's glycine nail polish, superfloss, piezos, whatever. But it is not easy to remove a fixed prosthesis, and there's got to be a cost associated to it. So in affordable dentures, what does your particular follow-up look like and maintenance schedule, especially for your fixed prosthesis? Or is it more of a go back to your regular dentist and just have them, I guess, if they know how to clean around it, they'll do it? Or what does your post-op protocol look like?
So again, I take care of all the work that I do, even maintenance wise, for my fixed or for my overdenture patients. And that one of the things that we said as part of the consultation, that because I do warranty, and the warranty goes towards the prosthesis, as far as if anything happened within the first 5 years, I'll take care of it for you free of charge. But in exchange of that warranty that I give you, because I know this is a big investment, you have to be also compliant and follow my maintenance schedule.
Mm-hmm.
I at least want to see you. So I like to see them after that I deliver it and everything is good. We make sure the bite is good as far as the fix. I say, you know what, let's see you back here in 3 months. I just want to see what are you doing as far as the cleaning, and we spend the time about them using the water pick. It's a must, it's not an option. You have to have a water pick and a toothbrush. When they come in the 3 months, I'm not taking anything out. I'm just asking them, I'm just checking on the gum. I'm seeing how is the oral hygiene are going here, because I want to catch things early enough. If I see a lot of, issue on the gum, you have food and things, you're not even brushing here, then I would like to catch that early. When they come at the second time, this is only happens at the beginning, to just make sure that this person is knowing how to clean, how to use the water pick and all of that. And then I see them once a year. I know out there in the literature, there is no like agreement, or people like, are you taking this out? Some people will say, no, you don't want to take the prosthesis out. They just say, go retorque your restorative screws. Some people will say, no, actually take it out, clean, change the restorative screws. Some might say that's going to acquire cost, it's going to be expensive. The way I do it in my book, they come, I see them, the 12 months, I will take the prosthesis out because I want to see what's going on. And then, yes, once I took the prosthesis out, I am changing the restorative screws as well.
Mm.
I think a lot of people might say, oh, but this is a lot of cost. Am I okay? The cost, the patient is paying for that maintenance visit. They're not paying thousands of dollars, it's few hundreds that they pay, and they know that this is part of what they have to do. Your oil change in your car, your roof change in your $1 million house. I'm not asking for too much. Maintenance is just, and I think sometimes that people or dentists, we feel shy to say you are going to have an ongoing cost on your maintenance. Maintenance costs money, like everything in life, like your house, your car, you name it, everything. I'm not going to be the exception. And they say, after I paid all this money, especially after you paid all this money, you want to come see me for the maintenance and pay for it. And I think part of the advantages I have as being part of corporation or having a DSO, my prices for these things are not as expensive as it is for other people. So for me to change restorative screws for my patients, and that's part of what I charge for, it's not a big charge. It's doable, and I would rather do it. I don't want to wait for a mechanical failure on my screw. I will change my screw because I can afford to change it without making it a financial burden on my patient as well. So that's my maintenance. They come every year. I take it out. I look what's going on. I retorque also my MUAs. visit everything basically, change new restorative screws. Those ones just go hit the trash when they come out of the patient mouth. And that's how I maintain this. The same thing I do for my overdenture, because overdenture needs this even more, because I know my inserts, I tell them these are rubbers. They're gonna wear off. Your tire in the car is gonna get flat. So come, let me change the tire. It doesn't cost much. We also gonna see how the abutments are doing. I retorque things back again, making sure I don't have a lot of deposits, calculus, or hopefully I don't have to see calculus, because calculus mean this is even being going on forever. I want to make sure that my patient also, depending on their age and manual dexterity, I sometimes, if they are on the most retentive at the beginning, maybe down the years, will start going a little bit less, because, or maybe the patient now have arthritis or something. I just have to be considerate of their manual dexterity to be able. Some of my old patients don't have the muscles to push these things out. So I change those also accordingly. I see them once a year. And at the beginning, I would say how I was doing it, I'll speak with them, and then people will call. And then I learned people don't remember. People don't call because the denture is going to be working, the overdenture is working, the fixed teeth is working. They feel like, oh, why do I go see the dentist? Or I want to save the money or whatever. So every patient who gets to my practice in their last visit after I deliver the final prosthesis, they get their once the year maintenance is scheduled before they leave the office. Right. I don't even wait to do this later on. I learn it through the years. You know what? It's better this way. So now when we call them, when it's time, it's still if it's not a good day, guess what? We already know you're due for it. We already brought it to your attention. We can schedule you next week or in a couple weeks if you're traveling or whatever the reason might be. It's an easy way for us and for them to have a reminder in there. I think that's very important. And I think we as dentists, we have a bigger role to educate. We have a bigger role to communicate these things and not try to cover anything or feel bad telling the patient that there's going to be a cost here. There's going to be a cost. This is life. Things can happen. I put warranties on my work because I know my case selection was correct from the beginning. I did things the right way as far as restorative space, this and that. So I know this process, nothing is going to happen to it. The only variable I have in this equation is my patient compliance on the other side.
Right.
And if you do that correctly, then we good. If not, then most probably you're not following my maintenance protocol, which means you're not going to be eligible for my warranty anyhow. But I do warranty everything I give to the patient.
Okay, that's a good question. So let's say, and this is last question because I know your time is valuable. I'm going to screen share one more time. Okay. So coming back to this study, this particular one by Dirks and Tomasi regarding incidence of disease. Peri-implant mucositis, we said 40+%, peri-implantitis around 20%. That means 1 in 5 implants are going to have some type of bone loss. In your world where you're doing a fixed prosthesis, where it might be cumbersome to take a prosthesis off, let's say you did 5 implants for this, 5 or 6 implants, and you get bone loss around a very high value strategic implant. As far, I can't take this out and leave a huge cantilever, so this single implant that has bone loss has to be addressed. Given that you warranty your work, and we know from multiple studies, there's a shoulder study that talked about surgically addressing implants with peri-implantitis. It's a must, right? It's not there's no decision, no consensus on which surgical protocol, whether you're using From's or Kotsakis or any of their, 50-step methods, but surgically addressing it is paramount. What does that look like to you? Do you take care of your own implant complications? Do you refer them to a specialist? Do you just take the implant, find another one, and start from scratch? What does it look like? Because I'll be honest with you. I see a lot of these come to me. I see a lot of full arch prostheses come to me because 1 or 2 of the implants have severe bone loss. And then it's this complicated discussion of, can we take this fixed prosthesis off? Is there going to be an interim prosthesis? Can we surgically address this single implant without removing the prosthesis? What do you do when you get those problems? And inevitably, I'm pretty sure you're not going to be here and be like, oh, I don't have any failures, right? There's going to be implants, even at the great Dr. Hassan's office, that have some
Everybody have
complications.
failures. Trust me,
Right.
I'm not gonna sit here and lie and say I don't have. I have.
But what does it look like in your practice? Logistically, I'm asking because I can see where it might take a lot to address the one failing implant in a system of 5 or 6 implants and a fixed prosthesis.
Usually, that's a good question. Usually, those cases, and that's where the maintenance comes in, because sometimes from the follow up on the maintenance and the x-rays that we took every year, part of the maintenance, you just keep comparing these x-rays and kind of see your bone level and how that is going. So, that is a gradual change. And usually, the maintenance and the revision of that is way easier because you catch it at an early stage versus some of those patients that they vanish and then they come back all of a sudden after 5 years or 4 years and they never went to anybody else, or sometimes this is somebody else's work. But when it's my work and I have the patient vanish and he comes back the 5 years or so, and now we have in a bigger amount of bone loss, that is this is need to be addressed. I think part of what makes things easy for me, yes, now because you've been vanished, that means I am have to going to charge you for it, but I'll take care of it because now you're outside of my warranty thing, right? Because you're not compliance if you disappear for 4 years or 5 years and come. But it's still, I will try to be considerate. We're not going to go hit this patient with the whole full amount from the beginning. So what I would do in those cases, I'll take the implants out and or take the prosthesis out, and if I have to replace that implant, hopefully I have bone around that. Sometimes if I have a different spot, so I can take that one clean, restore that, put some graft in there and choose a different spot and proceed by making them a temporary healing, because now I can't really use that because it's not gonna work. So I have to make you a temporary one. Now I'm digital, it's easy. I'll scan, the lab will just, do the redesign. I print the temp here and I give it to the patient. And then we have to wait for the healing happen. And then in 6 months, I'll go ahead and give you a final zirconia again. Sometimes it's that exact area that there is no other bone with that. Like we just have to actually graft, wait after we do the construction in that area, reconstruction, then I have to use that specific spot. I don't have no anywhere else to go. I can go ahead and put this patient on a removable prosthesis meanwhile.
Okay.
That's
Okay.
one way for me to do it. So, or at this point, we also will discuss, because I don't like to go just treat a problem without knowing in the first place why the problem happened. Because I could do all of this and then the story repeats itself. So I need to sometimes get to the bottom line of this. Is something changed now in your medical history? Is something happened in your life now that you think you're not going to be able to maintain this and fulfill the requirement to maintain from now on? Guess what? We can always go and reconsider changing the restorative option. Maybe I will go a step back now and put you on an overdenture and convert this. I got to remove my MUAs, convert this, and give you maybe a snap. Because now it's easier for you to maintain and to clean. So in some few cases, I had to go a step back and actually from a fix, we go a step back to an overdenture because now you can clean better. But I always like to know why this happened. Is it especially sometimes when it's just a negligent thing, it's kind of happen generalized. So you're going to have bone loss in multiple implants. Sometimes if it's the local area, then I want to know why this guy is failing so bad and everybody else looks awesome, right?
Right.
So it helps knowing the reason why things are happening. And I always say, teeth tells you a story. The same way when you look at somebody's mouth, especially when they come with teeth that's worn down, occlusion tells you the story. The pattern of the teeth tells you the story that's happening in this mouth. Sometimes also the failure of the implants have a certain pattern. If we just slow down, not jumping about, oh, let me take it out, clean, graft, and can we just slow down? Why did we have this happening to begin with? So this story doesn't happen again.
Very fair. Fair play. So, do you ever find yourself trying to save an implant, or if it's an implant that you feel, maybe it's not just a millimeter and a half of remodeling that we got, during the first couple months. This is actually a progressive lesion. You take out, graft, and or find a new spot, or come back and revisit the same spot with a brand new implant, right?
I think I did this saving thing with one case in my whole career because I it had to do with the medical history of that patient that I just getting surgically involved too much was not the right time for us to do it. So I had to end up polishing all the rough part of the implant, smooth that out, and accept a tissue attachment just to buy time. The
Right.
concept of buying time, sometimes I did it like in this case. I do it a lot also sometimes with natural teeth. A patient might come to me that we know these teeth are questionable, but for different reasons sometimes, budget sometimes being the biggest reason why I had to stage things out. We'll say, okay, let's do this one arch at a time, or let's take the very like immediately need to leave teeth that they're really hopeless, and the rest of the teeth are not in best shape. They're not going to survive for long term, but I can buy some time by putting a partial there for you, and you just maintain it, keep it clean at least, so we can keep it healthy, and we can work on the other arch. That part I do a lot because life is not ideal. You wish as the doctor you can do everything all at once. Sometimes medical history wouldn't allow you, sometimes budget wouldn't allow you. Sometimes the patient is like they have the budget, they this people are scared of the dentist. We are scary people. We really have to know how to connect with our patients. Sometimes the patient, you know what, doc, you're gonna take all of my teeth together in one? No, 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 no. Let's. I say, you know what? Let's do one arch at a time and take you through this easy, so you don't have to be scared of me. So there is multi-factors that they kick in here. I think the whole idea is to just have a comprehensive approach. Have an idea how to do things is one part, but also why you're doing what you're doing, why you blend what you blend. I think is the secret for everything to be successful.
And when you do it, right?
And when you do
Or
it,
when
yeah.
and so we'll wrap up there. And I want to say one of the refreshing things that I've gotten from this conversation is, despite when you work at a corporate office or part of a corporate partnership, there's often the perceived image that everything that comes through your door gets a cookie cutter approach. And part of that is the solo practitioner dentists that are trying to malign corporate entities. That's the talking point. Oh, you go there and they get cookie cutter approaches. But I'll be honest with you, I've been in this for a while, and I've talked to a lot of doctors, and a fair amount of them from your particular company, and I do see that to some degree. And another, with some of the doctors I've talked to a large degree. And that's why this conversation was so refreshing, because you have explained your particular practice philosophy based on acquisition of knowledge, acquisition of experience, and guided experience. So not just, hey, I took a course this weekend and I went out into the world and did it 100 times and we'll see what happens. Not that type of experience. So you were very methodical and very intentional about the type of experience that you received to be able to build you to the amazing clinician you are today. One of the things that I've come across, a lot of practitioners, they'll post these cases and you're looking at it, you're like, dang, why did you do all this? Did you try saving teeth? Did you maybe say no? And the response is, oh, well, we informed them, but they chose this. And I am so refreshed by you saying that there's times where you just got to say no. Patient comes in, they might, and it hurts because they might have their checkbook ready to go for this $20,000, $30,000 treatment. They say, doc, I don't want to deal with these natural teeth anymore. Yank them. I want implants. And you got to look at them. And the integrity of Dr. Amel Hassan is that if this patient right now does not fit what they're asking for, you have the integrity to say, ma'am, sir, this is not the right time to have this for you. And I love that about you. I absolutely 100% respect that, and I wish more clinicians would follow your lead. Well, listen, thank you so much for your time. It was a pleasure talking to you. As special as I knew you were when we first met years ago at the ICOI, you've done nothing but affirm how special you are as a clinician, as a citizen, as an educator. I'm looking forward to seeing you in Kansas City. Where can everybody find you? And I'll make sure that all those details are in our show notes when I put this particular one on YouTube and on Spotify. your Instagram handle, your office. How do you want people to be able to come across Dr. Amel Hassan?
So basically, I'm available. I have two practices in Florida right now, one in Leesburg, one in Winter Haven. That's where I practice in between the two. In social media, people can find me in Instagram, Facebook. I'm also big in LinkedIn, but I think my Instagram is being more active lately. We also have a business page in Facebook where people can go look at the locations and some of the cases that we post in Instagram. We'll also post them.
All right. And what's the name of your Instagram handle?
It's Dr. Amel Hassan.
Dr. Amel Hassan. Well, listen, thank you so much. To all the listeners out here, you already know my parting advice to you is listen, read, learn, and if you do that, you're only ever going to improve. With that, we'll part ways and we'll see you and talk to you soon. Thank you.